I would like to invite on the stage the moderators for the session, Dr. Naveen Ganju, Dr. Nipun Verma, Dr. Goldie Longjam, and Dr. Smith Bhatia.
The chairpersons for the next session, Dr. Jasmeet Dhingra, Dr. Acute Hamal, Dr. Dilip Sharma, and Dr. Kirit Solanki. The speaker for the first talk, Dr. Pradeep Bhaumik. The tea break will be after this session.
Should I start, sir? So good afternoon, everybody. At the outset, my greetings to all of you and regards to all the teachers. And I congratulate the organizers for organizing such a big event over here. And my respect to chairpersons, moderators, and all dignitaries present over here. I have been advised to discuss on changing epidemiology of acute viral hepatitis. And this is very important today to understand this very simple thing also, as because whenever we talk about liver, most of the time we we talk about jaundice. I mean, as a common man. And when you talk about the jaundice, the people understand is viral hepatitis. And historically, viral hepatitis was, in fact, only two, that is serum hepatitis, which is bloodborne, and infectious hepatitis, which was hepatitis E or waterborne disease. Subsequently, we had the third group, that is non-A, non-B, and we found enterically transmitted E virus and parenterally transmitted Hep C virus and other virus also. So finally, we do have now 5 viruses. A, B, C, D, and E. D is incomplete virus. A and E are waterborne or fecal transmitted, and B and C bloodborne virus. So it is, the issue is finalized now. We do have 5 viruses, and these are all discovered when 1990. The many issues like including the molecular biology of hepatitis viruses has already been finalized. But which is not finalized is the epidemiological data of acute viral hepatitis. There are a lot of scarcity in the epidemiological data on viral hepatitis, or particularly acute viral hepatitis in our country and outside, that because of lack of diagnostic tools, particularly in a clinical setup, where do we work? Because even few years back, we had no investigation facility like hepatitis A or hepatitis E. Resource limitation setups are there in many countries, including ours. Asymptomatic cases and spontaneous resolutions are there. Short-term and population migration is important. Disease stigma is very important as far as viral hepatitis or jaundice is concerned. Policy priorities on acute viral hepatitis was never an important area of priority or area for the policy matters. Particularly, we might be talking about sanitation, water, hygiene, but not about the acute viral hepatitis. Focus on chronic hepatitis is more, particularly hepatitis B and C, and lack of national guideline on acute viral hepatitis. But one thing is very important, the global burden of disease, which was studied as early as 1990 and is still continuing as a World Bank sponsored program, scientific program. It has given a lot of data to us. And in 2019, the data published, which was published in 2021-22, it has shown very clearly that acute hepatitis A is the major cause of acute viral hepatitis over the world. And second is acute hepatitis B is the second cause, followed by acute hepatitis E and acute hepatitis C. And as far as social demographic index is concerned, which is not only economic issues, but it also includes academic or educational issues and fertility issue of the female up to 25 years of age. And this composite index has shown that high HDI is related to less number of acute viral hepatitis. So this is a very important data which we got now. Same data, global burden on acute viral hepatitis, which was published subsequently in 2021, that was the last data published. In fact, published in 2024, it was up to 1990 to 2021. The whole data has shown that there is a gradual decline of the acute viral hepatitis over throughout the globe. And the hepatitis A and hepatitis B is significantly reduced, but this reduction is not exactly the number reduction, total number, but definitely hepatitis A has reduced even in as a whole throughout the globe, but absolute number has not reduced, rather it has increased in number of the countries. The overall burden of acute viral hepatitis is highest in low and middle income regions. So these are some of the observation of this 20 or 30 years of observation by the global disease burden, global burden of the disease. What is the absolute number in 2021? We found that acute hepatitis A is around 160 million over the throughout the globe. It is B is 63 million, E was 19 million, and C was 7 million. And it is anticipated the incidence of A, B, and C will further decline over the next 15 years. But interesting finding is that hepatitis E is projected to increase, and we will discuss this subsequently. The global burden, we see that it is present. Acute hepatitis is present all over the world, but it definitely differs from country to country. Like Africa is having higher prevalence, and followed by India and other countries, Southeast Asian countries. But American and European countries are having low prevalence of acute viral hepatitis. Changing epidemiology of the acute viral hepatitis is very important. Changes in the epidemiology of acute viral hepatitis are driven by improved sanitation, vaccination programs, and evolving risk behaviors. Global incidence is generally declining. Shifting trends towards the older population, that is the most important area. Why? That's why we should know it now, that shifting trends toward the older population are increasingly at risk of severe disease, and some regions face persistent or new challenges. If we take the individual, these four viruses, we will see that undergoing a paradoxical transition globally. Hepatitis A, as low and middle income countries improve sanitation and hygiene, they move from high to intermediate or low endemicity. Young children are less likely to be exposed. With more adults lacking immunity, outbreaks in older population are in rise. HIV infection is more likely to be symptomatic and severe in adults. In general, the cohort of aged 50 years and older, case fatality caused by acute hepatitis A can rise to 1.8 to 1.5 to 4.4%, which is much less earlier. Male patients with AHS showed a higher case fatality. This might be due to the comorbid conditions like diabetes, hypertension, and immune status. So, in case of hepatitis B, what we found, that routine infant vaccination, which was studied in our country in 2011 and in other countries as early as 1990 to 95, has dramatically altered the landscape of hepatitis B. The prevalence of chronic hepatitis B infection among children under 5 dropped to less than 1%. The burden of acute HBV has shifted to unvaccinated older adults and specific high-risk group like people who inject drugs or PWID. New strategies like targeting preventing the mother-to-child transmission and increasing adult vaccination should be a new target area, and it will definitely reduce the hepatitis B infection throughout the globe and increase coverage of treatment for all the patients. Burden of acute hepatitis B is very important. It is more in the Western Pacific and African region, and it is gradually declining, as we found that in 2022 it is only 254 globally, and Telangana and northeastern states of our country are having higher prevalence of hepatitis B. Hepatitis C is reducing, or it is less. Acute infection is comparatively much less, and directly acting antiviral drugs have reduced the global prevalence of hepatitis C. But hepatitis E is interesting. It is particularly prevalent in developing regions. A recent study forecasts the continued rise in HIV rates and deaths among adults over 40 years of age, and vaccine for HIV is not available except in China. And factors which increase the hepatitis E is inadequate sanitation and water supply. Zoonotic transmission is very, very important. Now we know, we are not knowing much about hepatitis E. Now we know more about the hepatitis E. It has got as high as 8 genotypes. So climatic change and natural disasters are important in human displacement, under recognition in developing countries. Parenteral and human-to-human transmission is important, and there are high-risk population. There can be chronicity among immunocompromised individuals. So it can be more in the pregnant women due to multiple reasons. And viral load is women in childbearing age is more comparatively. So finally, the vaccination is very important. We know about hepatitis B vaccination. We all are practicing, or everybody is receiving it. But hepatitis A vaccine is not much popular in our country due to multiple reasons. One of them is cost is very high. But definitely time has come to vaccinate hepatitis A. We have got both combined vaccine, a single antigen vaccine. This can be given from 1 year of age. And 2 doses is sufficient. One is after 1 dose, after 6 months, you can repeat the second dose. After 18 years, you can continue with the same dose, that is 0 and 6 to 18 months. So, or you do have a combination vaccine of hepatitis B and hepatitis A that is to be given at 0, 1 and 6 months. So, vaccination can be a good alternative or good method of preventing hepatitis or acute viral hepatitis in our country and globe. HIV vaccine is not available with us, but it is available in China. Probably in India, it will come by the end of this year. So finally, to conclude, acute viral hepatitis represents an important global health problem, and an improved understanding of the burden of IVH is required. Changing epidemiology can cause more complication of IVH, including ALF among adults. Research and efforts have often prioritized chronic hepatitis B and C, implementing multi-sector strategies including robust vaccination program and public health approach is essential to reduce the global burden of acute viral disease. Thank you very much for your patient hearing.
I would like to invite on stage Dr. Neeraj Saraf for the next session.
Thank you. I would like to thank the organizers, Dr. Anil Arora, Praveen and Ashish for inviting me here. And Dr. Arora was also my teacher in DNB, 2000 to 2003. So thank you, sir, for inviting me and giving me all the knowledge that you have given me over the years. So we'll switch gears and go to a clinical case and discuss some contentious issues in acute liver failure. And these are the expert panel discussants with me. I think Ankur is not here, he couldn't make it because of some injury. So we have Naveen, Nipun, Dr. Goldie and Sumit to take us through this case and answer the questions. So this is a 23-year-old male. He came to us last year, about the same time, I think around September or so. Loss of appetite for 7 days, jaundice, vomiting and fever for 5 days. He had altered sensorium, about grade 2 hepatic encephalopathy for 1 day. And when he came to us, he had just low-grade fever and almost normal vitals. So these were his reports on day 1. So he had a high TLC, 24,000. He had an INR of 3.1, a bilirubin of 9.3, liver enzymes ranging from 4 to 5,000 AST, ALT. His creatinine was normal, and his hepatitis A virus IgM was strongly positive. We did some other tests. His LDH was very high, and we found out that he was G6PD deficient also, and all other causes of acute liver injury were all negative. He did have a high procal and slightly high CRP. So when he came to the hospital, in view of worsening sensorium, he was put on ventilation and airway was secured, and his vitals were, he had some tachycardia, blood pressure was normal. So this is day 1, a patient diagnosed with young male hepatitis A, bilirubin of 9 and INR of 3. He had a fatty liver on ultrasound. We did a CT scan because of the encephalopathy, which showed diffuse cerebral edema. And we do optic nerve sheath diameter in our ICU, which was high. So normally, and we'll come to this a little later, normally it's taken as 5 to 5.5. So he had a high optic nerve sheath diameter, which suggests cerebral edema. So the diagnosis was hepatitis related acute liver failure, and it was hyperacute because the jaundice to hepatitis to encephalopathy interval was about 4 to 5 days. So, Dr. Goldie, now we have a hepatitis A related acute liver failure. We just had a talk on viral hepatitis. So, what is in your practice, what are the etiologies you see, and how do you think the management differs, and do you think the outcome of different etiologies is different? Viral versus drug versus autoimmune?
Good afternoon, everyone. This is a case of acute liver failure due to hepatitis A. In my practice, I usually see viral hepatitis as the cause of acute liver failure. Acute liver failure is a serious life-threatening disease with a mortality of around 30% and characterized by the encephalopathy and coagulopathy in a patient with rapid deterioration of the liver. So the cause of the acute liver failure is very important, and one must be having a very extensive evaluation to find out the cause of the liver failure. Why? Because, for example, paracetaminofen or the paracetamol or acetaminophen or pregnancy-related acute liver failure have a better outcome without liver transplantation, spontaneous recovery, around 60 to 70% without the transplant. And as for viral hepatitis, which is the most common cause in Asia or in the Northeast population, the non-A and this hepatitis A and E, that is non-A and non-B, that is B, the hepatitis A and E have a better prognosis with spontaneous recovery compared to B. And other
what about drugs? So let's say ATT-induced ALF,
so
what do you think of that?
The ATT-induced liver injury or the other drugs like complementary or alternative medicine, they have an intermediate prognosis without a liver transplant, around 20 to 40% spontaneous recovery. And also like shock liver, they have an intermediate. And the bad prognosis would be with Wilson's disease, like they have a very dismal prognosis without transplant. And the other bad prognosis might be autoimmune liver disease if the patient does not respond to the steroids.
Yeah, so I totally agree. So I think viral, I think we all agree, has a good prognosis, and we were just, I was just sitting in the back discussing with Dr. Aroda. Hepatitis E seems to have disappeared. We only see hepatitis A, and they do fairly well without a liver transplant and will come. So this patient had a bilirubin of 9, INR of 3. When he came to us, he was in grade 2 hepatic encephalopathy. Now, Dr. Naveen, I want to ask you, when should a person, we have a lot of gastroenterologists here who may not be at transplant centers. They may have small liver ICUs, or they have their practice or working in a hospital where transplant is not available. So when should a patient of acute liver injury / acute liver failure be shifted to a specialized liver unit with transplant facility? So I'm not saying that they are shifted for a transplant, but when should they be shifted for better care or in case they need a transplant? So do you think this patient should have been shifted?
Yes, should have been shifted. There are a couple of reasons. One is, if a patient is meeting the criteria, that is little late, kind of, that time you want to list them or plan for a transplant. If the numbers are getting worse, that means the liver enzymes are going high, the patient is coagulopathic, any encephalopathy, the patient should be thought about a transplant or should be shifted to a liver transplant unit and start counseling, because transplant takes time. But meeting the criteria, what we talk about, they meet a criteria, then we shift them, I think we are already late.
Yeah, so I think this, and probably I would think that this patient was in early encephalopathy, and maybe electively ventilating them and shifting them would be a better idea.
Always better.
So these are the EASL guidelines on these are not for transplant, these are for when to shift to a specialized unit, and for rising INR, renal dysfunction, encephalopathy, a bilirubin of more than 17, shrinking liver size, this is what the easel says. So I think this patient with INR of 3 and hepatic encephalopathy probably was the right decision to come to a transplant center. Now coming back to the case, so this patient was started on broad spectrum antibiotics, and measures were taken to reduce cerebral edema, which was evident on the CT scan. We started him on hypertonic saline, NAC infusion. He had ammonia of 149, and again I'll come to this. So we started CRRT in this patient and counseled him for a possible transplant. So any ALF that comes to us, we prime them about transplant, that it may be needed and maybe they should at least identify a donor. And a lot of times, most of the times, we can probably get away with a transplant also. So, Dr. Nipun, what's your practice of using antibiotics? Because these are common issues. A lot of times you hit them hard with, strong antibiotics. Or what is needed? Do you give them antifungal prophylaxis? What antibiotics do you use?
So, well, if you look at the guidelines from American Society, the ACG, the EASL, they all recommend against prophylaxis. So, what do we mean by prophylaxis? Means before the initiation of systemic inflammatory response or a particular signs of infection. While in our setup, the baseline prevalence is much higher and the rate of death because of sepsis is much higher as opposed to raised ICT. So, in a patient who has grade 3 or 4 encephalopathy who is intubated with IV lines, definitely we start empiric antimicrobials. Again, the patient if has worsening organ failures, let's say bilirubin and coagulopathy which is worsening, encephalopathy which is worsening, these are the patients one must, and again the data supporting such recommendation is not there, but it is extrapolated from observational studies suggesting that infections lead to high mortality in patients with ALF, and infection contributes to raised ICP. And the most common death now today is 70%. Last paper we published from PGI, 70% of deaths were because of raised ICT or sepsis. Sepsis was 50% or so in these series.
Yeah, so I think I agree that most Western guidelines say don't use any antibiotic, but I think all of us would agree that we do use.
We do use.
So so if there's no organ failure, no obvious thing, we would probably start them on a third generation cephalosporin or a piperacillin tazobactam type of combination. And of course, if you have cultures, then you start.
So in a patient with shock, we generally start with meropenem plus minus gram positive depending upon the number of IV lines. Non-shock patients, community directly, a patient is coming to us, we start ceftriaxone. Piperacillin tazobactam, if there is a risk of MDR, ESBLs, then we start with pipra. Regarding the antifungals, this is our policy, 72 hours of broad spectrum, generally piperacillin or meropenem based, no improvement or worsening of shock, we empirically
then
start on antifungals.
Otherwise, yeah, we don't start them upfront, we don't start.
Upfront we don't.
So this patient had, we did a CT early on, and there was cerebral edema on the CT scan. Dr. Sumit, how do you diagnose cerebral edema? So are there any bedside tools? What do you use? CT is not the best test to diagnose cerebral edema, because you don't get edema on CT unless it's fairly advanced. So early cerebral edema, what do you use? And so between bedside tools, optic nerve, ammonia, what are your choices and what are their roles?
I agree with you, sir, because CT, by the time we can get to see edema, patients are generally have worsened.
Right.
So one is the daily changes in mentation to assess whether the patient is coming in grade 1 or grade 2 HE and then they're worsening over a period of time. If the mentation is worsening, ONSD, like optic nerve sheet diameter, is the easiest tool available in critical care ICUs, which can be easily done bedside. Non-invasive gives us much more information, very quick cutoffs. Anything more than 5 is taken as increasing in intracranial pressure. And CT brain, yes, obviously in advanced stages, if the patient's mentation has worsened, we do get it done, but we don't rely only on CT brain.
So if you have to take a decision on starting CRRT, for example,
so
what would you base it on?
Ammonia levels generally worsening.
And what would that ammonia level be?
So the literature says it's around 150, 140. If the
So
patient's
some
mentation is
papers, I think
worsening, we have cut
124
a
to
module.
150.
Yes.
So I think if I would add here, only one thing is that we need to all this ONSCD and transcranial Doppler. The serial things are very CT.
Yes.
You cannot keep
Yes.
the dynamic changes. If there is
ONSD you
Optic
can
nerve
do
is
every day.
so easy to see. It's a
Yes,
bedside thing. And I think you will all agree that invasive ICP monitoring, I think no one does. I think it's become obsolete now probably.
And I think those who don't have the ultrasound, hyperreflexia is the earliest sign of raised
Encephalopathy
ICD.
presents in.
And we can check for planters every day. That has to be done 6 hourly. At least we say that to our
Right.
students.
So I think this is just a paper to show that ONSD, something cut off above 5.5 is usually considered as having cerebral edema. So this patient again has cerebral edema. He is on the ventilator. And so the next question comes, how do you manage cerebral edema? So again, Dr. Sumit, what do you use commonly? How do you start? Would you put them straight away on CRRT? Would you try hypertonic saline
So
first?
CRRT only like if the ammonia is very high and the patient's mentation is bad. Otherwise, hypertonic saline is the first go-to.
And what's your dose? What's your target?
So I think the
Sodium.
we have available only as commonly as 3%.
3% saline. Yeah.
So we start with 3%, we give them as infusions and we target a sodium value of around 145 to 150. And the literature says 30%, 20% salines, but we don't have availability.
Yeah, I don't think.
available,
Yeah,
so
I would be scared.
it's
also
not
to
available.
use
So
them
we start
probably.
with 3%. We have used mannitol, but the usage has gone down now because if the patient has a concomitant renal injury, then we don't use it. Otherwise, mannitol can be used in 1 gram per kg bolus doses to bring down the cerebral perfusion. Ventilation is another method to reduce the cerebral blood flow
You
to
keep the
hyperventilate.
PCO2 at about 35.
At around 25, 30 towards the lower side. And CRRT, yes, if the patient is worsening, CRRT.
Yes. So I think hypertonics. I think mannitol is slowly going out of because of the renal side effects. I think hypertonic saline is safer, and this is a recent paper in Journal of Critical Care showing that hypertonic saline actually did not lead to too many complications, and the survival in patients who got hypertonic saline was to the tune of almost 75%.
We used to be worried about central pontine pylorisis with hypertonic saline.
Yes, sir. So if you give them at the right, obviously you have to monitor the sodium, and if you give them at the right rate, and I don't think we've ever seen any patients.
So that is
developing-
also got to do with whether the patient has an acute liver failure or a chronic hyponatremia. So chronic hyponatremia, we correct it very rapidly, then the chances of CPM or EPM.
So CRRT definitely, I think we all agree that I think has become the standard of care, and this is a recent meta-analysis showing favoring CRRT in most patients with cerebral edema. So I'm not going to go into details because of lack of time, but I think CRRT is a standard of care now, and I don't think there's any debate left. We used to have a lot of debates on CRRT earlier, but I think there's no debate. So coming back to the patient, these are day 3, so we started him on CRRT, we gave him hypertonic saline, antibiotics. On day 3, the patient's INR has gone up to 4.9. His bilirubin has jumped to 18 and his creatinine has gone up to 2.2. His enzymes are coming down. So, there's an increase in the bilirubin, there is an increase in the INR, and there is some degree of AKI now. So before again going back to what we did with this patient's INR is almost 5. Naveen, so what are because I think this is again a very contentious issue of correcting their coagulation. So I think that ALF is a rebalanced hemostasis, and you have equivalent anticoagulant and procoagulant factors. How do you manage these patients? INR of 5, 6, do you correct it for any reason at all?
Unless if there is any bleeding or we are doing any invasive procedure, I don't think we should correct it. I know we get scared looking an INR of 5 and all that, but these patients actually with overcorrection can lead to worsening portal hypertension. They actually can have a portal vein thrombosis because they are really hypercoagulable. So important thing is if we are not doing any interventions and if there is no signs of bleeding, I think we should refrain.
So I think the message
and the TEG and the ROTEM of course to help us in case there is something bad.
Yes, so they can be used viscoelastic tests, but I think most of us still use INR, and these are again the EASL recommendations. that no use of FFP is recommended unless you are doing ICP monitors, which we don't do, and unless there is active bleed. So even if you're putting a central line or the arterial line, there is actually no need to give fresh frozen plasma, and that's a message I would like to give. So day 3, there is a rising bilirubin, rising INR, the creatinine is going up, there is some metabolic acidosis. He's on CRRT for 48 hours, the ammonia is still not come down, actually it's gone up. There is some metabolic acidosis, and we considered this patient for liver transplantation. So again, Naveen, would you take, so do you think this patient is a candidate for transplant? Worsening encephalopathy, no improvement in ammonia.
Right now, yes, because
INR of almost 5.
As we said, this is dynamic, and there is worsening after whatever medical management you could do. This patient is on CRRT already, and things are worsening. Your INR is 4.9. Your bilirubin is going up, which could be cholestatic, but the patient's ammonia and sensorium is still not better. So yeah.
So do you use any model like KCH or Alfed, or do you just see the trend?
So KCH is a good model, but it's a static model. We need to use dynamic models. MELD score is there, more than 35 you see an Alfred score, which we see at day 3. I think these are the models that we should use, being
So
dynamic, how things are.
So I think when we look at ALF, we have to look at totality and not just the numbers. I think you have to look at his encephalopathy, his need for ventilation, worsening on CRRT, ammonia levels, acidosis, renal dysfunction. So I think you have to look at, it's not just about numbers. I don't think you can just base any prognostic model just on numbers, and I think you have to look at the patient in totality. So actually this patient only met 2 King's College criteria, the bilirubin and the INR, because he's between 10 to 40, he has hepatitis A and he has hyperacute. So actually he didn't meet the criteria for transplant by King's. But if you look at the Alfred, actually he had a score of 5 to 6, which meant that he had a very high mortality. So there is a big discrepancy between these models itself, and I personally don't use any model, and I would just go with the trend. So quickly, I think we're going to run out of time. This on day 4, this patient, so we talked about transplant, they were still looking for a donor, but on day 4, the patient's oxygen requirement increased. He had fever, his creatinine went up to 2.9, he was started on some inotropes, and you can see the CT scan, the lungs look bad. So we put the transplant on hold. Do you agree, anyone, Dr. Goldie, Sumit, that should we have gone ahead with the transplant, or you think these are now sort of contraindications for at least an immediate transplant?
I think there is a sign of sepsis in this patient, worsening of organ failure.
Right.
So we would do something called as biofire or ETS multiplex PCR to find out what is the source of infection and treat accordingly. And fungal infection we should not cover here with Anidula fungin, because chest fungal infections are not candida, so we generally cover with
I'll just take 1 or 2 more minutes. So obviously we did not transplant this patient at that point. Any role of Plex?
So well, in the presence of sepsis, no. In the absence of sepsis, yes, we do start. So there are 3 big studies. One which you are showing. The previous one was from Larson, high volume plasma exchange. Benefit was seen in non-transplanted patients. Then standard volume Plex from ILBS. There was 40 patient study, CGH, and they showed improvement in transplant-free survival. This is the largest, the real world study showing no benefit of plasma exchange. So well, the question here, the answer here is that we have to select our patients very carefully. Patients who have coagulopathy and liver dysfunction, as this patient, a combination of plasma exchange with CRRT is individualized decision which we take at bedside.
Yeah, so I think, I agree. I think Plex is still debatable. I'm not sure how much it helps, and there are a lot of...
I would like to ask you, when do you consider Plex over a CRRT? This patient is not responding to CRRT, so or in combination with Plex.
This patient has sepsis and renal dysfunction, acidosis. I would not do Plex in this patient. So we just continue.
And in which scenario do you actually go?
Like he said.
What we do at PGI, resource constraint situations, patient in a volume overload situation with mild deranged renal functions, who has electrolyte imbalances, metabolic imbalances, in addition to raised ammonia and grade 3 or 4 encephalopathy, cerebral edema, CRRT as upfront, plasma exchange where the bilirubin and INR values are increasing, skyrocketing, in the absence of sepsis, these are the patients we add Plex. Now CRRT, if not affordable, Plex remains an option. So till the time sepsis is not happening, plasma exchange.
So we obviously did not do Plex. We continued this patient on CRRT, and I'll just quickly go through the course. So day 15 and day 28, his actually liver function started improving. So his liver improved, but he had multi-organ dysfunction. He was on inotropes, he was ventilated, he was still on CRRT. So he had modes, but his liver has actually improved. And we continued the CRRT, antibiotics, antifungals, vasopressors. By the end of a month, his inotrope started coming down, his oxygen requirement came down, and he was off the ventilator and decannulated. Day 47, he was actually shifted to the room off the ventilator. Eventually, his creatinine improved, and on day 52, he was discharged. So this is not, I'm not saying this is a usual case, but this patient, because I think the liver improved, he was a young person, so we could manage the multi-organ dysfunction, and this patient improved. So this is just last couple of slides, review about 10 years ago by Will Bernal, acute liver failure, a curable disease by 2024. So I'm not sure if it's totally curable, but I think we're getting there. I think the ICU management of acute liver failure has improved significantly, and a lot of these patients, especially viral etiologies, we are able to actually save them without a transplant. This is just our experience of hepatitis A, ALF in the last few years. We had 52 patients of HAV-related ALF. 88% patients had hepatic encephalopathy of more than grade 2. 44% had AKI. We had 96% survival, and 92% survived without a transplant. Only 2 patients out of 52 actually needed a transplant, and this is in the last 3 years. So with good ICU management, and especially hepatitis A, viral hepatitis, you can actually save most of these patients from a transplant. So my take-home message is etiology is important. Viral has a good etiology, drugs don't. Antibiotics, I don't think we should jump the gun, probably use broad-spectrum antibiotics, third-generation cephalosporins are good. No need to correct coagulation in these patients. There is rebalanced hemostasis. Cerebral edema, optic nerve sheath diameter, bedside tools, and maybe a CT scan are good options. Ammonia is very important, and I think it's a very important prognostic marker also for deciding for transplant. Usually a cutoff of 124 is taken to start a CRRT. Managing edema, I think we already discussed. You have hypertonic saline, hyperventilation, CRRT, etc. Plex, I think the role is still debatable. Maybe in selected candidates you could do a Plex. I think this is very important when to shift a patient to a liver ICU. I think Naveen answered that. So I would, rising bilirubin, rising INR, and I think any encephalopathy, the patient should be at a transplant center. When to transplant, I personally don't like scores. I think it should be a combination, and you need to see the trend, worsening labs, and like I said, see the patient in totality and not just numbers. And I think with good ICU management, a lot of ALF actually can be treated without transplant, especially the ones which have a viral etiology. Thank you.
What is Dr. Nikhil said, in Western countries, antibiotics are not given. I agree. In Western countries also, infection is the most common cause of death in liver failure. Our antibiotics are not given because giving prophylactic as a curative antibiotics does not decrease the mortality. And that is the same in India. Though infection are the most common cause of death, but giving antibiotics does not help. Therefore, antibiotics are not being given. Second query was hyperventilation is almost out of scene now to decrease cellular edema. It has shown that it does not help, so most of people do not use it. And third, when CRRT was not helping, my opinion, in my practice, I would have gone for plasma exchange. Citizens. And fourth, I just want to know, was it worth adding antiviral like surafenib in this patient?
Sorry?
Surafenib, was it worth adding antiviral drug in this patient?
The patient?
Yeah.
No, no.
No, but people have used surafenib in hepatitis A, in the acute liver failure. But
No.
recovery was used of
No,
surafenib.
no, no, no. I don't think an acute liver failure would have any role. So, yes, so I think this patient did improve on CRRT. I don't think we can say it because his liver parameters improved, his need for ventilation, the ventilatory requirements came down. So he actually went into multi-organ dysfunction because of the kidney failure. He was G6PD deficient, and he had pneumonia. So I think the other organs took over, but his liver actually improved. And I think in this patient, CRRT did help probably.
I would like to add a comment here. As hepatitis A has become a most common cause of viral acute liver failure in India, the universal immunization program in India does not include hepatitis A vaccine as a mandatory vaccine. It is an optional vaccine. So as the children nowadays are not getting subclinical infection because of A, majority in 13, 14 or young adults are getting acute liver failure, why doesn't the government or the hepatologist, the stalwarts and hepatologists, introduce the hepatitis A vaccine compulsory in the universal immunization program?
I agree with you. I think hepatitis A, we're all seeing so many patients now. And I think because we are behaving like the Western world now, and we don't get subclinical infections.
Good afternoon.
Chairperson, sir.
I would like to ask one question. This is not regarding the hepatitis, infective hepatitis, but it is regarding the autoimmune hepatitis, which is very much prevalent among the females. It is rare, but nowadays we have noticed more and more number of autoimmune hepatitis are noticed. And what is the preventive and the treatment modality in this subject? Thank you.
So, autoimmune hepatitis related acute liver failure is uncommon. I personally feel that most of these patients have ACLF and not actually acute liver failure. If you look at autoimmune, the acute presentations or people coming in with altered sensorium, most of them would have a cirrhotic liver. So they behave more like ACLF. And most of the times in autoimmune ALF or ACLF, they are not candidates for steroids. So most, because of the current recommendations, I think Nipun and his team do a lot of work on autoimmune hepatitis. But above a MELD of 26, 27, most people would not use steroids. So I think autoimmune ACLF, autoimmune ALF would most likely end up going for a transplant rather than medical treatment.
And just want to reiterate that plasma exchange in the presence of infection or sepsis do quite a harm. We have seen in our patient population that these patients have low expression of HLA-DR after plasma exchange. They acquire secondary infections, and obviously there are multiple lines going on, and infections can also peep in through that also. So in the presence of sepsis, ALF, ACLF, there is no flex in presence of sepsis.
Neeraj, any role of TJLB, especially seronegative AIHs, some chance for avoiding a transplant? If you see still inflammation, no cirrhosis, no necrosis.
Yeah.
Because you've seen people improve.
Actually, no. I think if the patient you think is in a situation where he can take steroids, then I think yes, we should do a TJLB. If he's beyond, let's say he's in encephalopathy or ventilator or something like this, then I don't think it's going to help. So it's a very good question. I have a patient today who has a bilirubin of 18. He has, lady, mild ascites and INR of 2.8. The MELD score is about 28. I've done a TGLB yesterday. I'm waiting for the biopsy results. No encephalopathy. Yes, I would give this patient steroids and, avoid a transplant.
We shy away a lot from doing biopsies, especially in ALF like picture, but we have had reversals and maybe just a thought.
So I would do a biopsy if I think you can give a treatment just for the sake of doing a biopsy and then saying okay, we can't do a treatment anyway, so I wouldn't.
Other problem which we've seen is HLH, and any comments? We're seeing a lot of HLH which is coming, especially because we're discussing steroids.
Secondary
HLH.
Yes, we do see that, and I think that has a poor prognosis, definitely.
I think the biopsy, what you were saying is it's good when there is no ascites, when there is no encephalopathy. I think these are the patients you will give them a chance to do well without a transplant or something. But if they are progressed, that's ACLF. So they might not, because you might get the liver better, but eventually they have this course of multi-organ dysfunction and they die of sepsis.
No, just so specific where seronegative AIH still remains.
As he said, no, those cases you have to choose.
I think if you are not talking of the ALF scenario, so any unexplained ACLF or even cirrhosis, seronegative, I biopsy all of them actually now. And you do find a lot of them having autoimmune. So I think the serology is really misleading.
I think we are over time.
So thank you.
Thank you.
Thank you for such an engaging session. We will now proceed to have a short tea break for 10 minutes and then proceed with our further sessions.
Good afternoon, everyone. Firstly, I'm very grateful to Professor Anil Arora sir, Dr. Praveen and Dr. Ashish for the kind invite. And on an auspicious day of the Teachers' Day, my best regards to all my teachers who are in the hall. Grateful to you all, and of course all colleagues also, because we keep learning. And today we'll try and learn a little more about our favorite infection. And not moving forward. Hello. Okay, we'll go to Prasad. So coming back to the topic for the day, our old hardy bug, which has been there for centuries, and more than half of the world is infected by it. But why are we discussing it today? Because H. pylori is now being classified as a class 1 carcinogen, proven risk with the CA stomach. As per Maastricht 6, all H. pylori infections must be eradicated. And since it's an infection, it's even now got ICD code. And the associated dyspepsia, what earlier we used to say H. pylori associated functional dyspepsia, now tendency to combine them, and because everything is H. pylori related. And even 1 in 12 of so-called functional dyspepsias do get treated when you treat for H. pylori. Now the last part is a little ambiguous from Indian consensus, Indian point of view, because as per this TIPI consensus, mass screening should be done in all those countries which have a very high risk of adenocarcinoma of the stomach. So we are probably not too much into that, because we do have a high prevalence. We now have high resistance rates, which we will see later. And mostly it's in our system, we are a single time contact. Most of the patients tend to not really be followed up that much. And HP associated gastric cancer we must prevent. Now we have molecular tests, and most important thing today now is your potassium channel acid blockers. And in this crowd, how many people are frequently using vonoprazan? Frequently few. Seldom? Okay. Never? All right. So basically show of hands is equal for all. So this is our status in India. As per our own IGJ article, which was a study of the multicentric, that 61% of patients among them will be symptomatic out of the 56% who are asymptomatic. And association with duodenal or gastric ulcer will be 81%. And what is important from our so-called thought of low risk of adenocarcinoma is that 80% of H. pylori is CAG-A and VAC-A positive. Gastric cancer we know is associated, but interestingly, it even increases the risk of gallbladder carcinoma. The hypothesis being that stasis, bacteria travels up, colonizes the gallbladder, and over there will be issues, because chronic inflammation leads to mutation, and bacteria generally hides because of the mucus layer. This is very simple. We know that what all it can cause: acute chronic gastritis, atrophy, malignancy, duodenal and gastric ulcers, and less than 1% even a lymphoma. So the key issues to be discussed are whom to test, how to test, whom to treat in India, how to treat in India, and how to test for eradication. So I'll ask Dr. Chaubal sir, whom to test and how to test, sir.
To both. There is a long list now. Actually, the list is ever expanding regarding the indications for testing these people. Starting off with the age-old indications, any patient having a past or a present peptic ulcer, may it either duodenal ulcer or gastric ulcer, any patient who has a history of, who has marginal B-cell type of lymphoma, which is maltoma, any patient who has gastric cancer, or a treated gastric cancer for that matter, or any patient who has undergone any resection for early gastric carcinoma, then first degree relatives of all patients, the first degree relatives of patients who have been treated for gastric cancer, that is there. Then there are several other conditions in which probably there is a kind of mechanism called molecular mimicry which results in production of some diseases like ITP, idiopathic thrombocytopenic purpura. If it is not getting treated properly, test for H. pylori, you may be benefited, and curing that particular infection might result in relief of this problem. Same thing happens with iron deficiency anemia also, unexplained, not properly treated. Look for H. pylori because H. pylori also is supposed to consume iron when it is in the stomach, and not only that, because of inflammation, the hepcidin mechanism works over there, and this can result in sequestration of the iron in the intestine. So iron deficiency anemia is there. All patients who are being treated with NSAIDs, all patients who are being to be kept on long-term low-dose aspirin, they also need to be evaluated. Then patients who have GPMCs, that means gastric pre-mucosal, pre-malignant lesions like chronic atrophic gastritis is there, intestinal metaplasia is there, they need to be treated.
Okay.
They say even that the patients who have some polyps, even the hyperplastic polyps, because many of these polyps are associated with underlying GPMCs, that is gastric pre-malignant lesions, so they also need to be tested for that. So these are some of the situations.
One excellent, sir. Thank you. This gastric atrophy bit, what is your opinion on that? All gastric atrophies, some specific locations?
See, there is a difference of opinion. All those countries where you have a higher incidence of gastric malignancies, many times the H. pylori results in corpus predominant atrophy. That is there.
Excellent.
In India, for example, it's more of an ental region atrophy which is there, which makes these patients prone for so-called duodenal ulcer, gastric ulcer due to some concept which is called the leaky roof concept and all these things which was proposed at that time. So we have more of in India, we have more of an ental predominant gastritis, and there you have a cross where you have higher incidence of gastric cancer.
The second part, sir, if you can, or if anyone wants to take on. Generally, in your practice, what would you recommend for testing?
See, as
the known options are in front of you.
Clinical gastroenterologist, we see large number of patients who have dyspeptic symptoms, and large number of them undergo upper GI endoscopies. So usually a biopsy done for a so-called rapid urease test or a histology is important. So that is what we usually do in these situations when we are performing endoscopies left and right. And as far as RUT is concerned, it is important to know that I have seen many patients taking a single biopsy, which is not recommended. At least one biopsy from the antrum and a corpus is recommended. But what they say these days is at least two from the lesser curve and the greater curve of a prepyloric antrum, one from incisura, and two from the lesser curve and the greater curve of the corpus. That is what is recommended in these situations.
So would you do that biopsy from 4 different places in all cases, sir, or based on certain endoscopic appearance?
We take at a random, where it endoscopically it is apparent, of course, in that situation we definitely take those biopsies. But otherwise also you can take
Good, that will increase the yield, but most of the people probably, if you find antral predominant, would focus only on one bit from there. And of course, if you are working up for iron deficiency anemias, B12s, other causes, then probably a little more. But if you have atrophy, then you must take it
from that.
Very valid point you've made, sir.
Non-invasive testing, of course, we now have breath test is available. Most of the time that the equipment which is available all across countries, they go for an ammonia breath test. But the one which is recommended as gold standard probably is either C14, which has a radiation risk, but more better is the C13 urea blood test analysis which is done. That is there. The stool antigen test is now coming in a very big way in these situations.
Yeah, so most of us are using RUTs, only precaution that never keep in a very chilled room, and generally as a rule, which we sometimes forget, don't be in a rush to report in 30 minutes. Sometimes it's a good idea and a good practice to wait for 24 hours.
There are some better rapid urease tests, like some liquid rapid urease test which is coming up, which gives results within 5 to 30 minutes, the so-called helicose test, I think.
So how many of us actually use the Kyoto classification in gastritis, honestly? I know very few of us do. But the fact of the matter is that here is a very decent validated system which probably we should get in our practice, because on a score of 8 from the 5 points of how much is atrophy, intestinal metaplasia, nodularity, thickness of hole and redness. So the marking is very simple and easy to remember. We must, because the reason is if it is more than 2, the score, H. pylori is likely, but more importantly, if it's more than 4, you need to exclude a gastric malignancy. So probably if on visual appearance you have the Kyoto going more than 4, kindly take more biopsies, like sir was saying that we should do it that way. This is that so-called light blue crest thing, which is one thing we'll rush through. UBT you all know. Now there is a hypothesis of test before you treat, which has been prophesied by the Maastricht 6, which basically is suggesting that you at a community level or a large level, you must do seropositive testing and treatment. But these things vary, according to me, from those countries which have got a high prevalence. You got to decide on that. Low prevalence, high prevalence, and that's how you got to follow. But bottom line is, whichever method you found it positive, treat you must. So Dr. Mahapatra, now that we've diagnosed, whom would you like to treat?
Any patient whom we have investigated for H. pylori, if it is positive because it is a type 1 carcinogen according to WHO, need to be treatment. Whether it is asymptomatic or symptomatic. If we find positive, they have to be treated. And patients who are on long-term anticoagulants, patients who are on long-term treatment with different type of PPIs, and they need to be treatment. And patients who have got a family history of gastric cancer, they need treatment. So these are the treatment modalities which are to be given.
Absolutely. And these are the challenges which we often find, drug compliance, people not taking full dose, and the role of resistance we're going to come back to fast. So Dr. Agarwal, which drugs and what dose do you recommend?
So the classical recommendation is the triple drug regimen. Yeah. So which consists of PPI plus 2 antibiotics, commonly using amoxicillin and clarithromycin. The dose of amoxicillin is 2 grams and clarithromycin 1 gram, 500 milligrams twice a day, and duration at least 14 days.
So the standard triple therapy combination?
Yeah.
Okay.
And
how long?
14 days.
Why not 10 or 7?
Because 14 days the eradication rates are more than 7 to 10 days therapy. And where clarithromycin resistance is a problem which is very common, then the recommended is the bismuth based quadruple therapies.
Yeah, fair enough. Okay. So now, which PPI out of these you would recommend?
As we know that PPIs have very important, acid suppression is very important in eradication of H. pylori. So we need a very long-term and potent acid suppression. And because of the polymorphism, some of the PPIs, high metabolizers, they may not be able to suppress acidity that much. So from that perspective, the rabeprazole or esomeprazole, they do not undergo metabolism. And
so now that Vono is showing 90%, would you prefer it?
Yeah, definitely.
Okay.
Because this is an important reason for eradication of H. pylori success rate.
All right. And how do you think do these vonoprazans and all these, the new one, the fecuprazans, how do you think they are better off than PPIs?
Because they provide you a long-term and potent acid suppression, which is a key parameter for H. pylori eradication, and that is how. And then.
All right. So because they are just blocking the thing directly, it's not a prodrug like PPIs are prodrugs. They can convert to the sulfonamide forms and then do it. So rapider action.
Yeah.
And more importantly, there's no limit of being fasting only to take a tablet. You can take it any time. But it's still early days. But these are the definite benefits of the new drugs. And what is more important is that it is effective in all circumstances. And it has also been shown that it is increasing the efficacy of the antibiotics which are being used along with that for H. pylori eradication. And first line, second line, reverse hybrid, all forms it has been used. Now this is one study which came out first as a first line use of Vono, wherein with the intention to treat analysis was with the PPI group was 96 versus 69%. And it definitely showed a big advantage. That was the first time. And this study group was around 70 odd patients in each. Then in a randomized controlled trial, it was also used as a second line therapy. Here the combination they used was with amoxicillin and clarithromycin, and you had Vono in one arm and lansoprazole in the other arm. So the difference was statistically significant, 93 and 76. Then they took a non-randomized branch, which was the resistant group, in which they found that the efficacy was almost 98%. This is another very interesting study for this thing where the bismuth quadruple therapy was compared with a dual therapy of Vono along with M.I.C.E, in which it was given in 10 and 14 days, two different groups, and they found again 92 versus 80% improvement. Now, clarithromycin, which we thought was only a problem of certain countries, and Japanese reporting it almost more than 60%, is our problem also now. And even in this subgroup of a Chinese study, which was a large number of 100 odd in each group, they found that dual therapy or triple therapy, whenever with vonoprazan was there, versus Lanso was better for resistant clarithromycin groups. Now, there is a subgroup of patients, another first time it's been used, the age-old tetracycline, which we had stopped using. And here in this group, they added tetracycline to Vono alone versus and they took those patients who were either known sensitive to penicillin or who had sensitivity test issues. Again, it was found to be having very high eradication rates. So, vonoprazan has definitely shown it's a good thing. Now, Dr. Nitin, can I ask you a question? Yeah. We've seen all this. Which regime would you think is the best to you?
So, I think for Indian studies and whatever data we have right now, maybe a quadruple regimen, looking at the resistance pattern today looks to be the first bet. Whenever you are looking at a regimen, always remember a regimen with bismuth is better than one without bismuth. One with, because of clarithromycin resistance, depending on the area which you belong to, maybe it could be replaced with either tetracycline or levofloxacin. Amongst the PPI, one which contains Vono or any other PCAB is much better than just a simple PPI. And a regimen which is 14 is better than 10, which is better than 7. So this, if you at least keep this, or like this forest chart shows, clarithromycin better than, but our problem remains about resistance. Bismuth I mentioned, vonoprazan I mentioned. There are different ways of inducing it. You can either go with sequential therapies, you can go with concomitant therapies, you can do 3+3, 2+4. So there are various combinations. I think a 4 upfront and 4 for 14 days looks the best bet in Indian studies. Only reason you have to decide between clarithromycin, will you exchange it with either a levofloxacin or a tetracycline.
So this forest plot, thank you so much. This forest plot very clearly gives you a present status of a meta-analysis which has been done of almost 30,000 patients, where with the reference being the standard triple therapy which we use, and now that bismuth is available in our country. How many people are using bismuth? Oh, that's a bigger number than the PCABs. That's nice. That's nice. So, oh my God, I'm sorry, we'll rush. This is another new molecule which I had never heard of, and the first time it is tegoprazan, another one of that, and another family, same. Again, in this one, when all the T ones are the ones with the tegoprazan, but here also they found that the triple therapy with the vonoprazan was better off than that. So the guidelines are very clear that PCABs are here to stay. Now, we still don't know, at least I don't, because it's just come less than a year back, that how many of us, what will be in our Indian setting the response, and safety data available is good, and would this extra acid suppression be helpful? What will be its drug interactions? And there may be a tendency, because of its so-called 90% efficacy and all, to try and use it empirically even before testing. Because failure is there because of antibiotic resistance, poor adherence and inadequate suppression. And this is what I wanted to highlight, that in Asia Pacific region too, the resistance is rising. And in India, the clarithromycin resistance has jumped from 17 to 34, almost double now. With 2-3 centers, I'll just show you. Levoflox has never been a very good alternative. That's why it's recommended either use moxiflox or in the quinolones if you have to use. And the good news is that an unused drug, like all rules of antibiotic microbial resistance, is showing a better hope and maybe a hope for future. So this was the study of the Indian task force, wherein it's interesting to see that SGPGI Lucknow 57% clarithromycin resistance, Chennai 60% resistance, Vellore 40% resistance. So others were relatively below 10%, but what is important is that clarithromycin resistance is our problem now. Probiotics, any opinion? Yes, no. Just we are running short of time.
No role, but if used, maybe 5-10% increase.
So in reality, there's enough evidence to say it doesn't really help. Duration, we have said, okay, 14 days is better. And which triple therapy, PAC or VAC? So right now, the favor of the all international studies is that mono-based therapies are better. How much it actually translates into Indian this thing. So far I think before we jump the gun, this is my thought that we should probably, we still have about 80% efficacy as of date of our conventional triple therapies. I don't think we should be jumping a little too soon. Should we use it as a salvage therapy, second line? Maybe. Or should, but as things are, people generally, everyone wants a quick solve to the solution. I'm not too sure how it will go in this thing. So if we were to put the American guidelines into the Indian thing, this is what is the most best out of that right now. That for a resistant case, this will be the better option to use. And testing for eradication, again, not truly done in our setup, but definitely patients who had a bleeding ulcers, or those, like you said, those who are going to be put on aspirins and all. So we must probably confirm eradication, preferably by a non-invasive mode or by an invasive mode as is required. So one case who's got a bleed, here definitely check for healing after 8 weeks. Another situation, if you got a nodular lesion, lymphoma, must eradicate H. pylori because outcomes of metachronous lesions and spreads later on post chemo are lesser. H. pylori eradication does help. And malignancy check for always, like we've already discussed, for H. pylori presence and family members too. Now, any patient who's on dual antiplatelets, even if there's the thing, you must eradicate with the best possible method. So to sum up, H. pylori we know is associated with all these increased risks, and now there's a lot of putative things about extra gastric things like CADs and Alzheimer's and all, but probably they're just a causation, not really an association. Eradicate we must, and overall benefit. Choose, we can have opinions of the house, what they would like to still go on for, but whatever we do, at least the conventional triple therapy kits of ours have just got 750 M.I.C.E, which that is one fact which we should always remember. Metronidazole not to be used in our country so far. Rifabutin, yes, has a role because it's one thing which cannot develop resistance to in those second line treatments. Tetracycline in second group may be helpful. Thank you so much. If I've forgotten anything, you can add, please. Because the disclaimer is that I just took on this presentation from Dr. Usha Datta 24 hours back. And like typical AB2 habits, sat out in the night and did something. So that's the disclaimer. But just I'm grateful to her for all the initial work she had done.
Little caveat, just remember in GI bleeding, chances of picking up RUT is a little bit less. In that case, only if you're going for a repeat scopy, please confirm. Secondly, in non-invasive serology, do not use it because it is not sure about past infection and present infection. But it is good in certain conditions where, and remember that it requires a very, very small load of bacterium. Otherwise, the bacterium load required is quite high for both RUT also. It requires 10⁵. And as sir said, 2 biopsies in the same well may sometimes help because there is some proximal migration of the bacteria also and might increase your RUT interpretation. Also said that you wait for some time you don't need 10 minutes to give a report. So these are just few caveats.
Regarding testing for eradication, what is most important is patient should be off PPI for 2 weeks before you test for eradication. And if he is taking a this bisphat quadruple therapy, wait for at least 4 weeks to check for eradication. Really, that's important.
Want to sequential, hybrid will become two things. So, and they want us to close down. Okay.
Thank moderators and chairpersons for the wonderful session. For the next session,
Just for my, how many people would be now after all this tending to use monofilament more?
For our next session, we would like to invite our panelists on stage, Dr. C.C. Chaubal, Dr. J.R. Mohapatra, Dr. Ashish Khandelwal, Dr. Sanjay Kumar, Dr. Anuj Sarkari, Dr. Rahul Patil.
and the chairpersons are Dr. Amit Man Joshi, Dr. Harshad Patil, Dr. Amit Basnotra, and Dr. Dibas Kharka. And the speaker for the first talk will be Dr. Gaurav Patil. So there might be some confusion. Yes, 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 yes.
But you can stay back if you are interested.
So, good evening, my dear friends and my colleagues, and to all my seniors and my friends over here, happy Teachers' Day. So, today Dr. Arora had given me this unique topic of discussing the dogmas, the pitfalls of identifying, deconstructing what is a hiatus hernia. And we all know it is the small hiatus hernia, the ones which are most difficult to define, as there is always an overlap and overdiagnosis in our routine practice. So we go by the standard definitions. We start with introduction, and then I'll start slowly talking about the modalities that are used. We know hiatus is a condition where there is migration of the upper part of the stomach or some other internal organs through the hernial orifice and called the diaphragmatic hiatus. The most common we encounter in our practice is the type 1, that are paraesophageal types. And this is usually because of the laxity of the phrenoesophageal membrane, and this membrane is nothing but a fascia of the anterior ligament of the longitudinal ligament which arises from the vertebra. And once the ligament becomes lax, there is also additional widening of the hiatal orifice. Small hiatus hernia, which is less than 2 centimeter size, these are often overcalled or sometimes even missed. Like in this diagram, you can see the right crust of the diaphragm is essentially the anterior longitudinal ligament, which is arising from the lumbar vertebrae, and they actually form the scissor-like bands, and they decussate over the esophagus and cause the constriction of the esophagus. Along with the crus, we have the G-junction flap valve, we have the sling fibers, and all of these are essentially in the anti-reflux mechanism, which we usually are now targeting as a part of reflux therapy. So today's discussion is mainly about the type 1 hiatus hernia, the sliding one, which is the most difficult one, whereas the easier ones to diagnose, that's the paraesophageal hernia, where the squamocolumnar junction, it has the hiatus, but the stomach usually takes the leading point and it starts to migrate. Type 3 is the mixed one, where you have both the squamocolumnar line as well as the entire stomach which is herniated, quite easy to diagnose with a barium, a CT, or even an X-ray. And 4 is the difficult type, where you have complete migration of the stomach, sometimes the omentum, colon, spleen, tail of pancreas. So what exactly is a barium telling us? Many a times patients come with a barium or a CT scan saying there is a hiatus. So when we look at the barium, the important things are your rugal folds, if you can really make them up, and the most important part is your diaphragmatic impression. There are two important landmarks, that is the A and the B ring. So the A ring is the highest pressure zone which is seen along the lower esophageal membrane, and the B ring is actually a ring which is seen only in 15 to 20% of individuals, which is actually dividing the entire phrenic ampulla into the esophageal side and the phrenic ampulla. So folds which are from the stomach going towards the hiatus side is a conviction to us that the hiatus is formed. But is the barium good enough? Now this is a barium of the same patient. The issue with this image is that you can see the black brackets over here where the barium is showing the hiatus hernia, and these are depending on the swallow sequence. So the size of the hiatus hernia can change depending on the sequence. In the first sequence, the patient has just swallowed, the LES is relaxed, the A-ring has relaxed. As a result, there is the hiatus is small. Now the A-ring is constricted. There is migration of the LES. As a result, the hiatus hernia is slightly big. So the criteria for defining hiatus hernia is actually the distance between the B-ring and the top of the gastric folds or the rugal folds. As a result, barium, CT scan or X-rays, one-time image is quite misleading in terms of diagnosing such hiatus. It is a very dynamic phenomena, the small hiatus. There is a lot of respiration, the movement of the crus, the peristalsis of the esophagus. There is a theory of distension of the food pipe, distension of the stomach, all of which add to the dynamicity of the hiatus, let alone the body position and the LES relaxation. Similarly, when we are doing endoscopy, are we really diagnosing hiatus hernia? Now, this is in the first 10 seconds of retroflexion. Current practice, we still don't have guidelines how much gas we need to insufflate, how much pressure do we create in the stomach. This is after creating more pressure in the stomach, you're sort of increasing the caliber of the hiatus, and which is more apparent to the distension. And you can see the flap valve, which is quite tight over here. The G-junction flap valve is slightly becomes effaced, and the same patient after maybe 120 seconds, 2 minutes of distension, he starts to burping and there's a complete opening of the hiatus. So how do we really diagnose these patients? First and foremost, we need to understand there is always a movement, a proximal movement of the LES during deglutition. The LES is not a static organ. It moves with swallowing, it moves with respiration, and whenever you do a lot of manometry, you see these LES migration, especially in patients who have motility disorders like eclasia or major motility disorders. The longitudinal muscle contracts and tries to move the LES upwards. And this is something which has been proven time and again in different studies, and this is one of the landmark studies which showed that the squamocolumnar junction, if you apply a clip over there, there's a good elevation of the squamocolumnar junction, and this is decreased, this is attenuated in patients who have an indolent or a hiatus hernia. Also noted is that the elastic recoil of these patients after they come, this is before they swallow and this after they complete the swallow. So elastic recoil of the phrenoesophageal membrane is lost, and this is because the entire laxity of this membrane is lost, and one real mechanism is these patients do not relax enough as compared to a normal patient. So how do we overcome this? And the most important part of diagnosing hiatus is a manometry. To me, understanding the LES morphology on your standard high resolution manometry is probably the gold standard. However, there are some pitfalls in it too. So type 1 hiatus is where there is complete overlap of the LES in the crura. The crura is slightly superimposed on the LES, and there is only a single peak pressure wave created on the spatial pressure variation plots. Type 2 is where there's actual distance between the LES and the crura, and you try to see two peak pressures, and there's a distance which is less than 2 centimeter. Now what happens in type 3 is the distance increases and the pressure inversion point changes. That is, the pressure inversion point is the point between the thorax and the abdomen, and type 3 is where the nadir pressure is greater than the gastric pressures, and type 3 where the RIP or the pressure inversion point is at the level of the LES. So what exactly is happening is when you talking about type 3A, type 3B, the distance is more than 3 centimeter. These are the larger hernias, and type 2 is one where you have a small hiatus hernia and are easy to diagnose on a manometry. And what you do in a routine manometry, if I just run through these videos, is this can be very easily diagnosed in terms of routine practice of esophageal manometry. So what did the Japanese do in this is they don't have too much of a gastric fold. They have a lot of gastric atrophy. So they try to study the same hiatus by means of the palisade vessels. What they feel, if you have the squamocolumnar junction, palisade vessels, and the pinch action of the crus on the same level, you definitely don't have hiatus. And what they found in patients who have the squamocolumnar junction and the palisade vessels at one level, whereas the pinch action at the lower level, these patients found to have more evidence of Barrett's esophagus. So they believe that this type of hiatus are the one who have more involvement of pathological hiatus hernias. Going to what is data saying, today we know combining endoscopy and high resolution manometry gives you the highest area under the curve, a good sensitivity and a specificity of diagnosing hiatus. We have data which shows endoscopically can exaggerate hiatus hernia because we still don't have guidelines to understand how much do we inflate. And across bariatric surgery, we know LSG is one such bariatric procedure. It's a refluxogenic procedure. So do we really have to do manometry or do we do endoscopy in such patients? What the bariatric surgeons feel, we must do a barium swallow. What we endoscopists feel, endoscopy and high resolution manometry is probably gold standard enough to escape out from big hiatus. So apart from just hiatus, you also know about the motility. We decide upon type of fundoplication. Nevertheless, HRM is always an adjunct to the deciding to the type of surgery, and it also tells you about what types of wraps have been created. Have the wrap slipped up in the thoracic or the wrap slipped below the diaphragmatic crura? Endoscopy has its own role, it has its own pitfalls, but it's always good to diagnose other conditions like you see in this. It's early cancer, you can see some eosinophilic rings over here. What we train our students, our fellows, is try to understand the G junction as an organ by itself. There is a lesser curve, there is a lip of the flap valve, there is a body of the flap valve, there is an intra-abdominal length of the esophagus. This is the anterior, this is the posterior, and the greater curve. So understanding the adequacy of the length of the intra-abdominal esophagus is very important, and the angulation of the flap valve and the lip. And there you decide upon which type of anti-reflux surgeries you are going to offer this patient. Particularly interesting is the Hills classification. It is site of subjective because grade 2 and grade 3 can differ between consultants to different physicians. However, now the American Foregut Society has now made it slightly more easier, slightly stipulated a methodology by which we can provide more accurate assessment. So it depends on 3 different factors. So intra-abdominal length of the esophagus, that's called the L, hiatal axial length, the hiatal aperture, that is the cardiac opening, and the flap valve. In the type 1, all these are enough. The omega shaped flap valve is maintained, the aperture is snugly, snugly held to the scope, while the axial length is 0, and then the aperture starts becoming loose, becoming open and wide. So you have grading of the hiatus based upon the LDF factor, that is the length, the diameter, and the flap valve. So grade 4 is something that is definitely a large hiatus, needs a surgical repair, whereas grade 2 and grade 3 can be something which can be managed with endoscopy or other therapies. Air sufflation tolerance test, I think this is a very unique and a very good method to know about anti-reflux barriers in patient. The video is not playing, but this tells you not only about the cardiac size but the aperture opening and the scope holding size, which is useful in predicting the LES function in patients who have GERD. Last but not the least, with AI is happening everywhere in the world, so there is AI even in such diagnostic procedures, and basic algorithms has so far succeeded human intelligence in saying that at least an inexperienced physician, they are least better than in terms of accuracy of diagnosing hiatus hernia. However, the overestimation in type 2 was as much as the experienced physician. So we still don't have good promising data from AI, but obviously with scaling and such things coming up, you'll probably have more data. Another important thing is the distension, the esophagus during the endoflip. I think this is one area where they are studying where you distend patients of almost 68 subjects who never had hiatus, subjected to endoflip. After distending with 60 ml of saline, they found 14 of them developed separation of the LES and the crura. Now this may propose a new mechanism for reflux, dysphagia, and that something has to be evaluated in the due course. So just taking home away some important point, hiatus hernia is important to be diagnosed for symptomatic small hernias. Endoscopy can over-predict such cases. AFS grading is standardized, should be validated across different centers, should be validated for effectiveness of treatment to PPIs and surgical therapy. Radiology, the sequencing is more important than a single one-shot X-ray or a barium. Esophageal distension with endoflip, I think, is something which can add new insights to reflux and dysphagia. And last but not least, as healthcare providers, we must look at cross-sectional areas, length of the axial length of the esophagus to identify hiatus hernias. We must interact with our industry partners, try to give them a broader insight of what we really want from AI so as to understand the better anatomy of these patients. Thank you for your attention.
Thanks, Dr. Gaurav. That was a very tricky and a difficult topic, very nicely covered. Shall we have question answer now?
Yes.
Yeah. So hiatus hernia, as you'll all agree, is reported variedly by different gastroenterologists, even by the same gastroenterologist. Maybe you have reported hiatus hernia 2 years back, and second endoscopy you will say it is not there. And very well highlighted by Gaurav that because it's not a static condition. So what do you think should our endoscopy report say in case of hiatus hernia? Is it the axial length which is more important or the laxity?
I think a very good question. So, I mean, the recent classification by the Fogart Society, they are looking at both parts. That's the length of the intra-abdominal LES as well as the scope holding sign. So, till now, how much gas to be inflated in the stomach is one thing which nobody knows, but the EPIS study that they are doing, they're inflating almost 18 to 20 millimeters of gas into the stomach and then observing the LES. What you have to look when you look at the abdominal length is how much is the cardiac opening. So first they focus on cardiac opening, and the classification itself starts first with the cardiac opening becoming bigger and then the length becoming. So a grade 2 AFS is something where the cardiac opening has started to become 1 centimeter too, and grade 3 is where the length is also now started. So first is the opening and then the length. Once the length starts becoming longer, that means you have proximal migration of the entire the LES and the stomach, which is happening.
So perhaps we have to refine our Hills grading more, rather than reporting that hiatus extending from 32 to 35 does not mean much.
Right.
What means is the laxity, and Hills is a good classification, but perhaps we need to refine it better, as you said. Any questions?
Thank you so much.
So due to some delay, we are not having the next talk on debate, and we will proceed with the next talk by Dr. Rakesh Kalpala on Barrett's esophagus.
Thanks, Varun. I thank Dr. Anil Arora and Dr. Ashish for having me here and also accommodating me a little up because I have to leave. So how many of you are really serious on Barrett's esophagus in your daily practice in audience as endoscopists? Yeah, all are serious, okay. But unfortunately or fortunately, Barrett's is not that high as incidence in India, or probably we are not looking it in depth, like how we have the eosinophilic esophagitis coming up in nowadays. So let me go into this. So this is again by a great doctor called Barrett's who has coined this, but he didn't mean it as Barrett's esophagus, but what he meant was the esophagitis as Barrett's. Coming to the definition, we all know the bookish definition, the condition in which metaplastic columnar epithelium replaces the normal stratified squamous epithelium lining of the distal esophagus, and the diagnosis requires on endoscopy the visual impression plus biopsy, which is the histopathology of main importance. So as Gaurav has told, it made my job easy. The anatomy of the lower esophagus is very important, where you have to see certain landmarks, the Z line and then the diaphragmatic pinch. So this is where you diagnose visually Barrett's esophagus, predict or suspect Barrett's esophagus. And the classification by Prague led by Pratik's group of C&M is primary classification with which we classify the Barrett's esophagus according to the circumference and then the maximum extent of the Barrett's from the Z line in the G junction. Histology wise, the main thing is what's called as SIM, specialized intestinal metaplasia, where you have the presence of goblet cells is the pathognomonic feature of diagnosing Barrett's. Of course, Japanese and British have got a little deviation. I'm not going into that in depth. But by and large, the society guidelines, as you see on the screen, the AGA, ASG, BSc and all, the extent is more or less same, more than 1 centimeter. Intestinal metaplasia is the commonest feature which you have to predict Barrett's esophagus. And again, how many of these Barrett's esophagus will go into adenocarcinoma? This is a meta-analysis of a large group of patients, and where we have found around the annual risk of 0.12%, not very high, but not actually very low. And if you see the dysplasia, there are 3 grades. One is no dysplasia, low-grade dysplasia, high-grade dysplasia. As you see on the screen, no dysplasia 0.2 to 0.5%, LGD is 0.7%, and high-grade dysplasia is the progression is 7%. So this is one where you have the non-dysplastic Barrett's esophagus, meta-analysis of 57 studies. So the progression into adenocarcinoma is very negligible, so you don't have to really worry about it. It's around 0.33%. But again, progression from low-grade dysplasia to adenocarcinoma is a little striking. It's around 0.5%. But progression of a high-grade dysplasia to adenocarcinoma is much higher, around 7%, which you really have to look upon and treat. So the data, what I was told to talk on in India, unfortunately, after 2011, 2012, or 2014 rather, I haven't seen any article being published from Indian subcontinent. And these are the few studies from different parts of the India where they have found the columnar metaplasia and intestinal metaplasia, where I think the PGI group has got the maximum of 11%, and then the other people followed. So risk factors again remain the same like any of the typical GERD: obesity, smoking, age increasing, male, and then chronic GERD with a large hiatus. These are all the typical risk factors. This is one from KEM group by Shobna, where they have found the risk factors of more than 45 years age, large hiatus hernia, and history of regurgitation in this study have shown as major risk factors for Barrett's. And again, there's another study from Vani group from North India, where they have found the similar thing, and there, as you see on the screen, the intestinal metaplasia is around 2.38% in that cohort of patients. Again, this is a famous NEGM article from Stewart group published in 2014, where they have found similar risk factors which are there. Then the next important topic is whom to screen and then whom to do surveillance. Screening, as I told, the typical risk factors of more than 50 years. Of course, the white race is not applicable to us, but chronic GERD patients, hiatus hernia, obese patients, history of smoking, tobacco use, and also history of any family history of Barrett's esophagus. Limitations to screening, as I told, patients do come to you only if they are symptomatic, but 40% of them unfortunately doesn't have any symptoms. They don't seek or knock your office door. And then if you screen also, you quite often miss Barrett's, or probably because of your busy practice where you do a lot of patients, you might overlook subtle Barrett's esophagus. The recommendations by and large by various societies across the world are almost same. The risk factors, number of risk factors, the age, chronic GERD, hiatus, and these are all the different guidelines from different bodies across the world. Coming to the surveillance, once you have the Seattle protocol is still the standard protocol where you take the 4-quadrant biopsies and then check for. I think one important thing what I would say practically is you should have a good sync with your pathologist. What you feel should be seen by your pathologist. That is more important, and should have a clever and syncing pathologist in your lab. So the shortcomings of surveillance, as I told you, we might miss it. The pathologist, if you feel, the pathologist might not feel it. And then most of the patients before getting diagnosed with Barrett's esophagus land up in your clinic in a full-blown adenocarcinoma. So they might have had Barrett's, but we don't know. And the surveillance guidelines, when you have this established evidence of a low-grade or a high-grade dysplasia, again, or more or less same in terms of American College or ASG or the BSG, where you do repeat endoscopy if it's a low-grade dysplasia every 6 months, and if it is a high-grade dysplasia every 3 months, and then try to take biopsies and prove that you are not going to the adenocarcinoma. So if at all these are not possible, now with the image-enhanced endoscopies which are widely there across the world, so you have this as a tool to diagnose if you don't have a good pathologist, or if you don't have the the ecosystem to do that. So where you have the digital chromoendoscopy, chemical spray, endomicroscopy, and cross-sectional imaging. We all have, so this is the poor man's image enhanced endoscopy, where you just spray acetic acid on the G junction, and then if you can see there is any difference in the take-up of the absorption of acetic acid, that itself is a direct evidence of picking up the dysplasia, and then you biopsy using the targeted biopsies. Virtual chromoendoscopy again is available for all the scopes. You have the Olympus, Pentax, and the Fujinon. They all have this chromoendoscopy, which again is easy to pick up. But again, it's not the gold standard. You have to have a biopsy targeted after this. Narrowband imaging, most of us know, and all the Olympus scopes have this. So it is again a high resolution endoscopy technique to enhance the fine structure, and you don't need any dye or a contrast to spray, only just a visual impression of your endoscopy is good. So there is a group from Barrett's International Working Group where they have classified adenocarcinoma and squamous cell carcinoma of the esophagus with these, which I don't go into the detail. It's available for all the fellows in the books. So this is how exactly you can pick up narrowband imaging, and probably if you have a high index of suspicion, then you do a targeted biopsies. So standard endoscopy versus NBA, this is one study in gut in 2013, where they found NBA has got a better modality of detecting the Barrett's esophagus compared to a normal white light endoscopy. So advances in imaging have come, though they are not widely available in this part of the continent. This is a artificial intelligence based wide area transepithelial sampling, where you take up the wide area sampling and then do a artificial intelligence accommodated algorithm model, so that you can pick up, the pickup rate is higher and faster compared to doing a conventional histopathology. So this is how the brush looks. It's not available, as to my knowledge, in India, but it's there in a few parts of Western world. Volumetric laser endomicroscopy is another one, where there is a there's a endoscopy with a 6 centimeter depth scanner, which will exactly scan, and then probably at that targeted area you can try to pick up the tissue. Then cytosponge, again not available in India, but this is just a swallowable pill, like a capsule. It goes into the G junction, and then you just have to do to and fro movements, so it will capture the mucosa from the G junction where you have a high index of suspicion, and then you do the immunohistochemistry markers on that. Furthermore, we have the mutation analysis. You have the, like any other biopsy for any cancer, you have the fish-based biomarker assays, and of course the immunohistochemistry markers, which won't go without for any pathologist nowadays. So management, I'm not going into, but it's not the topic which I thought I have to talk on. So we have wide varieties of management, like the medical management, which includes PPAs and the vonoprazole, the PCAPs. Then if you have Barrett's with a high volume reflex episodes, then you have the endoscopic fundoplication therapies as well as the surgical therapies. If you have full-blown, early adenocarcinoma, low-grade dysplasia, you have the EMRs and the cryoablators. And if you have a full-blown or a high-grade dysplasia, the surgery is always there. So just to conclude, primary detection of Barrett's esophagus, good white light endoscopy, spending some good time with a good preparation, and I would say without, in the same breath, that a good conscious sedation is always important, because we don't want the patient to move here and there. Then the benefits of image enhanced endoscopy, as I told you in the last couple of slides. The poor man's image enhanced endoscopy is spraying the acetic acid spray. So I would say Barrett's esophagus is not uncommon in India. We have to revisit that and then try to look again in depth. And the research work, what I would propose at this standing on here is how best we can screen and identify Barrett's esophagus. What are the clinical and biomarker risk factors to predict the progression of non-dysplastic Barrett's when you suspect? And how can surveillance or technique yield may be maximized with all the modalities what I have told, which are cost effective obviously, which should be cost effective. And what are the risk factors for prolonged or failed ablation, if at all you do with cryoablation or the hybrid APCs? And what are the appropriate post-ablative, because we as hardcore endoscopists, we do some ablative therapies and we feel Barrett's is gone, but that's not the case. We have to develop our own surveillance interval models. So with this and permission from chair, so I would all invite you all to have your presentations as a research for the IGIE, because till this December end, it's free for acceptance. They are not charging it. Thank you.
wonderful talk, Rakesh. Though it was on surveillance mainly, but if you diagnose the high-grade dysplasia, as you said, we will do a repeat endoscopy after 3 months. If the lesion is small, would you like to do an EMR or do an ablation? What is the protocol?
So if you
and where do you subject them to surgery?
You mean to say after ablation or after diagnosing this?
After diagnosis.
After diagnosing this, obviously if you have a high-grade dysplasia or metaplasia, then you have to go for aggressive therapy. If it is a low grade, then probably that's where you can use either a hybrid APC or a cryoablation.
So even for low-grade dysplasia,
you can follow it up actually. You don't have to straight away go into that. But if it is progressing, then or you need to close follow-up with multiple repeated biopsies.
Right. So you'll do a repeat examination, repeat demonstration of low-grade dysplasia, and if at all it is there, then you would like to ablate even a low-grade.
And probably you can use the image enhanced endoscopies to do a targeted biopsy.
And the preference is ablation or EMR?
I would say ablation is still holds good.
With APC?
At least, with APC, hybrid APC.
Hybrid APC. Yeah. Yes, sir.
Rakesh, do we have any data of the interval period between development of Barrett's and development of adenocarcinoma in Indian patients?
That's what, sir. So we don't have it. From 2014, I haven't seen any article. Actually, we should do some multicentric studies.
That's a big problem.
That's a big problem.
Because we don't see Barrett's that often, probably.
We don't see, there are two ways in that. We don't see Barrett's. There is Barrett's, we don't see Barrett's.
That's possible.
Rakesh, sorry, hi.
Hey.
What is your experience? This is one of the few places where now AI is probably, you got enough of data on AI in the Barrett's. Other than intestinal metabolite, this is the only place where it is worked.
Yes.
What is your experience, one? Secondly, we know that though it is not part of recommendations as of now, but it is going to be part of how the exact question is, are you happy if somebody says there is Barrett's, no dysplasia, leave him alone, or will you biopsy every time, or is AI good enough for you? That is the actual question.
So, as I have shown you, Nitin, the AI is evolving the wide cut biopsies. We don't have it in India as a model, but that is something which definitely scores. Likewise, the gastric cancer, if at all the models are going to develop. And I say on image enhanced endoscopy or pathology that there is Barrett's, I won't leave. I personally feel I have to follow up more closely than what you don't.
So for a polyp, we are happy that AI says it is less than 10 millimeters, no evidence of dysplasia, either resect and throw or just leave it alone.
True.
But for Barrett's, we still want to do
We need to have more data on that. But that's one area which is easy to work on.
It was a very interesting talk. Is Barrett's an endoscopic diagnosis, or we have to reserve the diagnosis after histology? How much, what is the so-called ultra-short Barrett's is
Short segment bar,
reporting?
Yes.
I think we should be little more careful in committing an endoscopic reports about the presence of Barrett's esophagus.
Yeah.
I've seen people becoming crazy about going through the literature and say it's a precancerous, and they keep on coming again.
Yes. Yeah.
So should be a little more careful in explaining to the patient
Yeah.
that it is not so common.
So I would say personally, only on endoscopy you conclude it is Barrett's is there or not is something which we should not do. If there is a suspicion, you do a histopathology and then see it's basically the safety of the patient and also safety of yours. Ours.
Thank you. Thank you, Rakesh.
So next we will have a debate on long-term management of reflux esophagitis. And for PPI, Dr. S.P. Mishra will speak, and for endotherapy, Dr. Piyush Ranjan will speak. And the experts will be Dr. G.S. Lamba and Dr. Sitaram Chaudhary.
Well, thanks to Anil and the team to give me 8 minutes, 37 seconds. I'll try my best to finish. So, we are not opponents, we are friends. So GERD is a very common entity, said to be about 15% in the world. And in India, it's about the same, 15.6% in the last study in multiple centers. It's a chronic relapsing disorders. The primary goal is to heal esophagitis, prevent relapse, and preserve the quality of life. PPI is a time-tested, proven symptom relief is there with PPIs. We all know about that. And we all, more than us, the orthopedicians and the cardiologists use PPI. So this is how PPI fares. It fares very well with unrestricted heartburn, heartburn with esophagitis, and best with erosive esophagitis. That's the bottom line. So these are the guidelines. AGA guideline to 2022, ACG guideline 2022, AGA guidelines, and the Asian Indian consensus. PPIs are the cornerstone of therapy for reflux esophagitis, GRD. And it has to be indefinite maintenance in LAC and D, that's erosive esophagitis. No way that anything can be used. Again, the same thing I'm showing over here. And only when it fails or the patient has some other problems on impedance, you find that there's more of volume reflux, then you resort to the so-called endotherapies, which themselves are not foolproof. So the healing power of PPI is increased for up to 8 weeks, and they are maintained. Twice daily, PPI have better improvement rates in erosive esophagitis. If you discontinue PPI, there are relapse of symptoms and recurrence of endoscopic lesions. A meta-analysis showed that recurrence of erosive esophagitis was in about 80%, and symptoms relapse was there in about 76% of patients, as compared to 29% with PPIs. If the patient was on PPI, 29% only relapsed. So the guidelines say that if you treat them with PPI, and only endotherapy is indicated if you have problems. And where is it indicated? Now this is the problem, you should understand. Not in grade C and D, only in grade A and B. And if you have a hiatus hernia of less than 2 centimeters. So in the mild esophagitis, there only can endotherapy be done, not in the severe esophagitis. So what's the fun in doing it? The problem is if you have a hammer, everything looks like a nail. And if everything looks like a nail, you are bound to fail and sometimes go to jail. So this is the pooled meta-analysis. If you see over here, the endotherapy works the same tune as a little less than PPI, 70%. And if you're off PPIs, how many people are off PPI? Say about half of them are off PPI and the others require PPI. In the same dose or a bit lesser dose, but they do require PPI even after endotherapy. So this is when patients with Hill's grade 1 and 2 and hiatus hernia of less than 2 centimeters, that's mostly with mild erosive esophagitis that you can do endotherapy. There are many methods of doing endotherapy. My Piyush will be telling you about that. This was a tempo trial when 81% of patients were off PPI at 1 year, but only 60% were off PPI in 5 years. Straight there's short-term benefit, long-term durability, we don't know about it. ARMA again is studies are only for 1 to 1.5 to 2 years. This was a sham control study that found that 6 months after therapy, Strata improved GRD symptoms and the quality of life, but did not decrease the esophageal exposure time. So that probably they mentioned that it's altering some of the nerves over there, which require the symptoms to go forward to the brain, and that is how it's working, because the acid exposure is the same. And the one thing they have not mentioned that if you have acid exposure, then what Rakesh was saying, you may have more of Barrett's esophagus. So though the symptoms are less, the acid exposure is the same. Again, you found meta-analysis. All the meta-analysis they found that the results were plus minus, and there were many complications. The incidence of perforation and bleeding was 2.4%, and total satisfaction was only 70% at 6 months. These are, I've plotted some of the studies. If you see over here, esophageal erosions, again, the forest graph shows plus minus. The only thing which shows a benefit is surgical fundoplication. Same true for acid exposure, same for resting LES pressure. So everything, whatever parameter was studied over here, the results were plus minus. So there are some novel endoscopic GERD therapies I've mentioned over here, will not go for, because of shortage of time, which are coming up, and probably they may hold good, but we don't have data till date. There's lack of robust data in single, they're mostly for single centers. Most studies are single center with small size, not incorporated in any of the guidelines, short follow-up, and lack of adequate control group. There's myths, multiple myths about long-term PPI, and I'm sure Piyush will be harping on it, that it does that and does that. If you go carefully, except for infections, the C. difficile infection, nothing has been proven. Cardiovascular events, cardiovascular deaths, kidney disease, pneumonia, dementia, bone fracture, gastric atrophy, gastric cancer, they're all being mentioned, but nothing has been proven. And people have been taking PPIs for dog years now. The adverse effects of endotherapy include chest pain, epigastric pain. These are the adverse effects, and many adverse effects are there. You can go through them. PPI is economic, safe, and easily available. We have been using for such a long time. It's very economical. In India, it costs few rupees. Availability is not an issue. Endotherapy, you have to have a good center. The cost runs to about 2.5 to 3.5 lakhs. You have to have a good center, you have to have that equipment, well-trained staff, well-trained endoscopists. PPIs can be prescribed by physicians. Here you require training. Patients usually respond very well on long-term. Complications are less, the mild side effects are probably no side effects. Here, significant proportion of patients require PPI therapy even after the procedure. So you do it in the mild cases, and despite that you require PPI. So that's, I'll end my case. And request my opponent to. But see, this is how they have a dogfight in the parliament, and then they have tea and they smile at them. So we are friends. It's not running.
So, good evening, everybody. So, Dr. Mishra has presented a very rosy picture of treatment of GERD. If the case was so simple, then there was no need for any other form of treatment for GERD. So, when we treat any condition, we need to know what causes the disease, that is the pathophysiology. Slides are not moving. Yeah. So, GERD, is it all about acid? If you look at the basic pathophysiology of GERD, there are so many other factors apart from gastric contents, esophageal sensitivity, esophageal G-junction integrity, LES dysfunction, impaired peristalsis, and impaired gastric emptying. What we are focusing when we say of PPIs is only on gastric contents, and that too in gastric contents, there are other contents rather other than hydrochloric acid, there is pepsin, bile acid, and there is a role of gut microbiome. So why PPIs fail? Because PPIs do not have any action on the acid reflux barrier. It does not alter the TLESR. It does not alter any other mechanism which causes GERD. And we heard a very beautiful talk by Gaurav on G-junction, the importance of G-junction in preventing GERD, and this is exactly where endoscopic anti-reflux therapy works, that it augments the G-junction barrier and thus prevents the reflux. So what are the challenges with long-term PPI therapies? The first issue is compliance. In a treatment where disease which requires lifelong treatment, the compliance studies have shown that nearly 50% patients do not have good compliance in long-term. Long-term efficacy data, I'll show you a slide about this, and then adverse effects which sir mentioned, but very conveniently skip the facts which are there glaring at your facts. So look at the adverse effects first. This is a 2017 data from AGA which talks about various side effects which it causes, and there are specified mechanisms of action where they have what they have mentioned in developing these facts. And he mentioned dementia. I was surprised that brain glial cells have a hydrogen potassium ATPase, and by preventing that, the degradation of amyloid is prevented, and that is why you have more Alzheimer's and even non-Alzheimer's dementia. And also in kidney disease, we are focused on more having acute interstitial nephritis, whereas CKD, the large studies are there, but we have been conveniently overlooking that data. And to quote the famous this thing, absence of evidence is not the evidence of absence. If you look at it in the more prospective studies, larger studies, we'll find those data. Now coming to the efficacy, if we see, this is again the same AGA document which talks about the long-term efficacy. If we look at GERD in patients with esophagitis and without esophagitis, here in patients without esophagitis, it shows that there is absence of long-term data and there is absence of any objective outcome data in the long term. So PPIs, which we considered as the gold standard, neither act at the pathophysiological level. There is a problem with compliance, the safety issue is not settled, and the efficacy is also not settled. So why do we need anti-reflux therapy? Dr. Mishra showed many of these treatments already. This anti-reflux therapy can be of 3 types: radiofrequency ablation, the mechanisms which he already mentioned, not very well studied, but probably acts at the esophageal sensitivity level and prevents the TLESRs. Fundoplication methods, there are multiple of them, and ARMS and ARMA, which are catching up because rather than having complex equipments, this can be done very easily. And apart from that, it is a single point intervention which keeps you free of PPIs in the long term. This is a snapshot, I will not, of the different procedures which we do, and I will show you some detailed evidence of all of this. As far as the data is concerned, the maximum data is with TIF. This is the trans-incisional-less fundoplication version 2. There are 5 randomized control trials. The maximum number of patients have been done with Strata. However, with Strata, there are no randomized control trials comparing with PPIs. There are sham control trials, but PPI control trials are not there. This Dr. Mishra showed, but he conveniently skipped these 2 things. The patient-reported outcomes in PPIs are better than as compared with RFA versus PPI, endotherapy versus PPI, and reinforcement therapies. These all diamonds are stacked in the favor of endoscopic therapy. The quality of life indices again are all better. He very conveniently used this, quoted the same meta-analysis, but skipped these 2. So the issues with ERT, they are real issues. There are short-term follow-up, lack of robust data comparing with PPIs. But here again, the thing is that the inclusion point of these studies has been refractory GERD. So how can you compare it with PPIs alone? You have these patients, you have to see that before and after therapy, the patient serves as his own control, and the improvement tells you that the patient is, in a patient who was PPI refractory, if the PPI use it decreased to nearly 50% at 5-year follow-up, that is a good result. Issues of safety, I will come to that, and cost, again there are cost effectiveness analysis, at least with TIF. Strata, again these are the data that shows that the meta-analysis of observational studies shows that this is better. The meta-analysis of randomized control trials, these are the sham control trials, not the trials with PPIs, that show that there is no difference in the objective data. The adverse events is nearly less than 4%, there is no cost effectiveness study. Now this is a recent publication, 2024, from UK, 10-year follow-up, and what it shows that nearly 45% of patients were not receiving PPI after a median follow-up of nearly 55 months. The median PPI-free period after Strata was nearly 41%, and only 3% of patients underwent subsequent interventions. And what this study found, that patients who were younger had a longer PPI-free period as compared to the older period. So this can be, as sir was mentioning, this can be used to defer surgery, and many of these patients might not require surgery. TIF has got the maximum data. Respect trial was the initial trial. Tempo, he mentioned, nearly 50% patients are PPI free at 5 years, and the health related quality of life indices are better at 5 years. Meta-analysis, again, it shows good results. Same at the end, there is 10-year follow-up which is available. The adverse events, I will specifically come to that. These are the adverse events. 2.4% was the figure which was mentioned: perforation, bleeding, and pneumothorax. But none of the patients died of these events. There was only 1 death in the entire study, and which that was not related to the procedure. And the cost effectiveness strategy, PPIs versus TIF, TIF wins hands down. This is again the recent data of TIF, 81 patients, and what it shows that the issues that have been raised about the effectiveness of endoscopic reflux therapies have been that they are not good at improving the objective parameters, but this is a study which shows that the objective parameters apart from the patient-related symptom scores also improve. Now, Rakesh is sitting here, the GERD-X procedure, 70 patients, sham control trial, all the primary endpoints, 50% reduction in GERD HRQL, better than the sham group, and PPI discontinuation more than approximately 2/3 patient at 1 year. pH metry again, that is the shortcoming at 3 months, better results, 12 months, this thing is not there. This is again a systemic review and meta-analysis of this anti-reflux procedures. Nearly 2/3 of the patients remain PPI free at 1 year, and the adverse effects are not there. M.I.C.E, as sir mentioned, it is a new procedure, probably a better one, but the data is much less. ARMS and ARMA. So ARMS is a thing which I mentioned that it requires much less equipment wise and it is easier to do. And again, the meta-analysis, if you look at the meta-analysis, 307 patients, but the inclusion point is all PPI refractory patients, and the follow-up is of short duration, but the procedure itself was introduced in 2020, so the follow-up will come as we go along. ARMA, again, 2 studies, one by the Rakesh is sitting here, 29 patients, 6 months follow-up only, but again, as we go along, ARMA came in 2022, the data will come. Now, this is a recent data, 2025 JNM paper on ARMA. I put it up here just to show that apart from reflux measures and pH, what we have talking about, this study shows the improvement in the G junction integrity and esophageal motility as we do ARMA in these patients. So, to conclude, GERD is a complex and multifactorial disease, and approach to treatment should be beyond that of acid suppression only. Impedance and HRM will help us in individualize our treatment approaches. This is a slide, this is a thing just at a concept level, probably bile acid sequestrants, alginates, GABA B agonists and TRPV1 agonists, all these will help, and endoscopic therapy is an option in patients who are not willing to take long-term PPIs. This is a 2025 ASG guideline. So patients who are not maintained, who require this treatment beyond 6 months, they can be offered endotherapy, and depending on these characteristics, you can choose between endoscopic anti-reflux therapy and the surgical therapy. So treatment of GERD, one size does not fit all, and PPIs have to be complemented by other modalities of treatment if we want a good long-term patient outcome. Thank you.
Thank you, Piyush. That was excellent. Any rebuttal from your side, sir?
Well, Piyush, why did you join medicine? You should have been a good lawyer. Liar. Don't laugh. So, he said, he showed the forest plot and said that everything was towards that. It was not significant. It was just at the line. And I told that. And of course, one size does not fit anything to anybody. In any medicine is nothing 100%. So you have to have options. But this option, I told you, he conveniently said that, I did not tell you about that, you cannot use it in LAC and D, where there are complications, or only PPI have to be used. How many of you use endoscopic therapy? 1, 2. And how many use PPI? Everybody. So I got the answer. So, and he said, this is the problem with, I've been a professor for many years, with us professor, sitting here, everybody. ये मैकेनिज्म है, वो मैकेनिज्म है, ऐसे है, मोदी से ज़्यादा हम लोग ड्रामेटिक हो जाते हैं। पिस्टल में क्या होता है? लोडिंग स्प्रिंग होता है, ट्रिगर होता है, घोड़ा होता है, बैरल होता है, हैंड, बट द इंपॉर्टेंट थिंग इज द बुलेट. सो पीपीआई वर्क्स एट द लेवल of the acid which is the bullet in GERD. You can have many mechanisms, of course I agree with that. So आप mechanism ठीक करते रहिए, esophageal motility ठीक कर लीजिए. I told you strata जो है, it only functions as there's something, it does denervation or something in the nerves so that you don't feel the symptoms. That's not the problem. The problem is, you can't, all the mechanisms cannot be taken care of. So that is one problem with this. But of course, I agree with him that you can't have one tailored therapy for everybody. You need many more therapies. Probably will be advancing. Now we have CABs and other things coming up. We'll be better off. And it can only be used in mild esophagitis, not in severe esophagitis.
Thank you, sir. So the point is that LA grade C and D, they have not been included in the trials. Once you push the envelope, once these studies are established, they will be included. And the bigger point which I mentioned, that all these trials have taken PPI refractory patients. So you are already comparing a group of patients probably who have got a severe disease. And if you look at the guidelines, at the end of 6 months, I showed you 2025 ASG guideline. All the guidelines are the same. Beyond 6 months of treatment, you have to give the patient an option of single time side effect versus years of facing an unknown side effect. Anything happens, we wash our hands. No, PPI can't do this because they have been probably made by God and
Dr.
sent to
Piyush,
us.
do you advise on first diagnosis of GERD, a patient you have diagnosed, do you advise him endotherapy?
No. So that is not.
So the comparison doesn't exist actually.
Actually, that is what I am saying.
So what Piyush said, that
PPI is for a different.
So this is not comparing apples and oranges. This is comparing.
Piyush said two things, very important things. आगे क्या होगा मुझे नहीं पता. अभी क्या हो रहा है आगे नहीं पता है. So आगे क्या होगा किसको पता है क्या होगा.
We don't even know the side effects of endotherapy in the long run.
And they are doing it in mild cases.
Mild cases in small.
आप लोग you are already friends, you know. You have made friendship. So where PPI works, we will go for PPI. Where it doesn't work, then in selective cases we will.
PPIs have been there for more than 30 years. So, you know, you have so much of knowledge about them.
Yeah, I think it's not a question of debate. We are talking about two different things. Everybody has to be by default on PPIs. What Piyush was talking of, a subgroup of the patients who on long-term PPIs because of the risk of the side effects can be offered a endotherapy in which 50% of the time you can get them rid of PPIs.
Absolutely.
That small group subgroup is grade B and C. If you have a large hiatus hernia which cannot be closed by endotherapy, that is enough. That is what we are trying to say.
Absolutely.
It is a multifactorial
The debate
disease.
does not start at
So
point
it's not
zero,
a debate
at
actually.
6 months.
Both of you are right. Everybody will require PPI. 50% of these patients can be taken in subgroup of the patient who do not have a large hiatus.
No, Anil, I have one problem there. Yeah. None of them has been randomized, double controlled.
We admit that.
This is a big problem. Whatever we do, we find an excuse to put it right, that this is right. This is the way you should be done. So till you have a randomized, at least a randomized control trial, forget about double blind, then only can we, and all the PPI trials have been double blind, randomized, controlled, blind trials.
It's more important to debate surgery versus endotherapy rather than PPI is universal.
If it is a large hiatus and it is a different group. What we thought was that if you have child the grade B and C esophagitis in a patient who does not have a large hernia, this is an OPD procedure. ARMA is a OPD procedure. So we do not have randomized trials, but if you can get rid of the PPIs in 50% of the patient, I think it is a welcome modality.
Sir, can I just take a minute? After your debate, I think most of us are more confused than we were.
That's the purpose of the debate.
No, I thought the purpose was to take the fog away. But Piyush, what is your experience, limited as it might be, about the benefits in the medium term, not the long term, since we don't have many long-term studies, in the medium term, in the context of the reduction of the dose of the PPIs? I understand that most of the patients will still need to be on PPIs, but many of them do well for a certain period,
So
6 to 12 months.
For 1 year, PPI reduction is nearly 66%, nearly 2/3 of them, and 4 to 5 years, nearly 50% of them.
Okay.
Let's not forget that now PCABs are there, and for on-demand therapy, PCABs are much better than PPI because they act immediately, they are independent of food, where PPI was much inferior.
Again,
So that fear about
Sanjay,
chronic
that's a
use of
conjecture.
PPIs might go.
We have to have studies with time. What you say is right, but we have to have studies and data to say that PCABs. You're right. Act very fast, nothing to do with food. Thank you very much, Piyush.
You wanted to ask something?
No, just who out of those two wants an ENRD patient? Dr. Mishra and Dr. Piyush both. ENRD, who out of you all want it?
ENRD.
No, I'll tell you that the data with strata which I showed, Rakesh's paper, gut 2022, 35 patients in each group, nearly 20 of these are ENRD patients. So it is a question of taking, if you have a volume reflux, I mean, esophagitis is a phenotype of severe reflux. You have to have nighttime reflux to have esophagitis. In daytime refluxers, erosions might not be there. The volume refluxers, if there is a small hiatus hernia, they will always benefit with some G-junction augmenting procedures. So ENRD might well be there. And again, we heard
PPI
that
PPI also are very poor out there.
PPI they fare poorer in patients who are ENRD. That is a known fact.
So if you have something else refluxing apart from acid and you have volume reflux, I showed you the slides. There probably this may help. Probably.
I think two important issues which we tend to ignore, willingly or unwillingly, are that the most important reason for reflux is something called transient repeated lower esophageal sphincter relaxation. Nobody knows what it means. Nobody knows how to diagnose. Nobody knows where does it start, where does it end. That is the crux of the problem. Not everyone will hiatus hernia. Everyone will hiatus hernia will have TLSCR, but majority of those with TLSR will not have hiatus hernia. So that cannot be tackled by PPI. Number one. PCABs, as Sanjay said, they will only take up acid. What Piyush was referring to, if you have a volume reflux, you need to tighten it by some means, whether it is ARMA or endotherapy or TIF or whatever you want to do. So unless you tackle these two problems, the TLSCRs and volume reflux, nothing will work.
Anil, TLSR can be taken. If you don't have the acid, even if a relaxed sphincter, only problem is volume reflux. There of course something has to be done, and you can take care of the volume by prokinetics, something like that. But I agree over there. Probably the endotherapy will help in volume, but that's a very small, minuscule group.
Baclofen acts on TLESRs, but the problem with baclofen is that it causes a lot of sedation and short-term action. Probably better drugs will come in future. Strata is one thing. We do not know how it works, but probably it works on TLESRs. TLESR is a predominant mechanism of reflux in daytime refluxers and patients who do not have severe disease.
Again, baclofen, the sedation is in a very small group of people, and there are data to predict that these people will have side effects of baclofen.
Okay, I think we have had an excellent debate, and what we have learnt is that probably we have to just choose when to use what, and who are the patients who are candidates for endoscopic therapy. I think with this I thank both the speakers. This was an excellent debate, and we end this session here. Thank you.
Thank you, sir.